Good evening, everyone. My name is Ware Harmon, and I'm the Executive Director of Town Hall Seattle. On behalf of our staff and our friends at Third Place Books, it's a pleasure to welcome you to tonight's presentation of Dr. Carl L. Hart in conversation with Professor Jennifer Oliva, part of our Arno G. Matulski Science Lecture Series. As we get underway, I want to acknowledge that our institution stands on the unceded traditional territory of the Coast Salish people, and particularly the Duwamish. We thank them for our continuing use of the natural resources of their ancestral homeland. And we thank you all for joining us tonight. The presentation will run around 60 minutes, including Q&A. To submit your questions once we get to Q&A, and frankly, all throughout the event, you can submit questions at meet.ps/Hart, and Hart is spelled H-A-R-T, by the way, or by scanning the QR code that should likely be appearing on your screen. You can use your smartphone to do that, obviously. We'll drop the link in the chat as well, and you can submit your question, as I said, at any time. We'll also try to get to as many questions as possible, and you can help us out by keeping yours concise. Remember, if you'd like to view the program with closed captions, you can click the CC button in the bottom right corner of the video player. Town Hall's adding new events and podcasts every day, and upcoming in February, Mountain Goats musician and writer John Darnielle discusses his latest novel, Devil House, with Luke Burbank. And Pulitzer Prize-winning journalist Matt Richtel joins us to discuss the new science of the immune system, presented in partnership with the Institute for Systems Biology. You can visit our website to join our email list and get the latest updates as more programs, as I mentioned, are added all the time. Town Hall's work is made possible through your support and the support of our sponsors. As I mentioned, this is part of our Arno G. Matulski Science Lecture Series, which is supported by Microsoft. But as you probably also know, Town Hall is underneath it all a member-supported organization, and I want to thank all of our members who are joining us tonight. If you share in their belief, in Town Hall's belief, that our community is energized and empowered through questions of politics, science, and culture, I hope you'll consider supporting us as well by becoming a member yourself. And there's membership information on our website, as you might imagine. Last, you will absolutely want to go deeper into tonight's topic by purchasing your own copy of Dr. Hart's book. And you can use the link in the chat below easily to pick up yours through Third Place Books. And we urge you to do that and ensure that all of the wonderful booksellers who proliferate in this community are able to thrive on the other side of the pandemic. And with all of that, Dr. Carl L. Hart is the Ziff Professor of Psychology in the Departments of Psychology and Psychiatry at Columbia University. Also a research scientist at the New York State Psychiatric Institute, Dr. Hart has published numerous scientific and popular articles in the area of neuropsychopharmacology and is co-author of the textbook Drugs, Society, and Human Behavior. Meanwhile, his 2013 book, High Price, a neuroscientist's journey of self-discovery that challenges everything you know about drugs and society, was the 2014 winner of the Penn E.O. Wilson Literary Science Writing Award. Jennifer D. Oliva is the Associate Dean for Faculty Research and Development and Director of the Center for Health and Pharmaceutical Law at Seton Hall Law School, where she specializes in health law and policy, FDA law, and complex litigation. She also serves as a senior scholar with the O'Neill Institute for National and Global Health Law at Georgetown Law and on the National Pain Advocacy Center's Science and Policy Advisory Council. Dr. Hart's new book, Drug Use for Grown-Ups, Chasing Liberty in the Land of Fear, is the subject of their discussion tonight. Please join me in welcoming Professor Jennifer Oliva and Dr. Carl L. Hart.
Thank you so much for that kind introduction. It's wonderful to see you, Dr. Hart, and thank you for allowing me to join you tonight. It's an absolute privilege, and it's a true career highlight for me to have this opportunity to speak with you about your wonderful book, Drug Use for Grown-Ups, Chasing Liberty in the Land of Fear. And I love the second part even more than the first. People want to hear from you and not from me, so I'm going to do my best to keep my questions short as much as it pains me, so you can do most of the talking. So I'm going to get right into it, if that's okay with you, sir.
Perfectly fine. Thank you for doing this, Jennifer. I really appreciate it.
The pleasure is mine. So one of the things that I very much appreciated about your book was how much important and often myth-breaking information about drug use you were able to convey to the lay reader in such an accessible way. As you and I both know, texts written by very fancy Ivy League scientists are often difficult reads, but that's certainly not the case here. So I wanted to start out by asking you what motivated you to write the book and who exactly was your intended audience?
Yeah, the motivation of the book came from actually the last book. I was on a book tour And then I had an opportunity to just travel the world. And then in doing so, I saw all of this hypocrisy. That is, large numbers of people using psychoactive substances, and they're primarily middle class to upper class people. Meanwhile, we have poor people, racial minorities, people who are despised, who are going to jail for the very activity that these sort of middle to upper class people are engaged in. And that's not to say to besmirch those middle to upper class people. It's just to say that there was this disconnect. And so I wanted people to understand that most of the people who support this multi-billion-dollar industry of illicit drugs are people who have means. And so I thought that, well, I myself am in the closet about this activity using drugs. And so I wanted to make sure that, well, I said, I put myself on the line and help people to understand that the vast majority of people who use these drugs are responsible people in their communities. And they enjoy this activity and they are not addicted, contrary to the stories that we're constantly told. And so I wanted to use my research in the lab as a way to help people to understand the science, but in doing so, doing it with stories, telling stories about my life primarily, because I didn't want to put other people on blast. And I try not to put other people on blast, even though I have encouraged other people to stand up on behalf of those people who have no choice but to be out of the closet, who are poor, people who don't have the resources that we have. And so, but I wanted to use myself as the sort of the constant thread that I pulled for this book. And so the major motivation was to try myself to live more honestly and to encourage other people to do the same. In doing so, I was hoping that we could change these drug laws in order to decrease the death and carnage, the incarceration, all of these sort of things that goes along with our dishonesty in terms of drug policy. And so those were the major motivations for this book.
Well, I have a bunch of additional questions for you about several of the things you just mentioned. But one I really wanted to start with was you do share with your readers in your wonderful last book that won the award, as well as this one, a little bit about your background, growing up in a predominantly Black part of Miami, which you describe in the book, and your early career trajectory. Would you mind sharing with us a little bit more about that tonight? I know you were an all-star basketball player in Miami and you were in the Air Force, and I'm not sure if people sort of know all the fascinating, interesting things you've done along your journey.
Yeah, no, thank you for mentioning that, because I think this is important. One of the things that I wanted people to understand is that I did 4 years in the military. I carried an M16 for the country. So when the people question my patriotism, I know more about the Declaration of Independence than these politicians who have lapel pins with the flag on their suits, and they don't understand what it means to be a patriot. You know, what it means to be a patriot, certainly from the military perspective, is that you stand up on behalf of those who can't stand up for themselves, and you make sure that you stand up in protection of people's liberty. And so that's what I got in my military service. And as you point out, I grew up in a Black community, resource poor, and I understood, or I began to learn what role, for example, racism played in drug policy, or the enforcement of drug policy, I should say. I came to understand these sort of things. And so I try to communicate this knowledge in all of my books. With this book, one of the things that is really interesting is that there are a number of people who come up from the backgrounds like my own, and they don't understand how the war on drugs, it's the war on drugs and not drugs themselves that are causing the harms in the community. And so I tried to show them how it's drug policy that has destroyed the community, and not drugs. And drugs are convenient scapegoats, not only for our communities, but a number of communities. And so my background helps me to see this a lot more clearly. For example, I have an older son who's paid the price in terms of he's been arrested for drug charges. I have relatives who've been arrested for drug charges. And I try and walk through the data, and I try and show people that, for example, Black men in our country make up about 6%, of the population, the general population, but damn near 40% of the prison population, largely because of drug enforcement of drug laws. And so I argue for some relief in these drug laws, to change these drug laws, because I know these drug laws are the things that have really hampered the progress in various communities. And I also understand, and I try to communicate this in the book, that the war on drugs and drug policy is really functioning as a jobs program for certain Americans. That is, we all know that law enforcement is benefiting from the war on drugs. Their budgets are increased, but we don't think about the role that the media plays in telling these simple stories about drugs and the people who use them. The war on drugs functions as a jobs program for people in the media. It functions as a jobs program for people like me who are scientists. I got my PhD paid for because I was studying drugs and the rhetoric surrounding drugs. And so scientists are invested in this war on drugs, although they pretend not to be. And in the book, in chapter 4, I tried to help people to understand how scientists are invested in the war on drugs. The war on drugs wouldn't be such a bad thing if it wasn't predicated on the subjugation of specific people in our society. So the war on drugs need to incarcerate various bodies, otherwise it doesn't work. People who are in treatment, who provide treatment, they're also benefiting from the war on drugs. When we think about this fact, the vast majority of people who use drugs don't need treatment. But the frame is always going to treatment. And that's one of the things I tried to make clear in this book. This book was not dealing with drug addiction, because drug addiction is a small percentage of what happens when we talk about this particular subject, drugs. And I tried to show a little bit how, for example, people who experience chronic pain, they are now seeing that they can't get their medications because of the rhetoric surrounding the war on drugs. Because we're saying opioids are so dangerous that people who've been maintained on opioids for decades and happily maintained on them, they are living a life that's worth living. We are now suddenly taking these people off of these medications because we have frightened the population and frightened doctors. They don't want to prescribe these medications. I'm trying to show people in the pain community how their struggle is connected with those people who are on the margins of society when it comes to the war on drugs. And so I was hoping that those two communities spoke and they see and they join forces in order to fight to have these policies changed. So I hope that the book helps people to see how those communities and other communities are, their struggles intersect.
Thank you so much. I'm going to follow up on two things, and definitely would like to hear more about your view on the opioid crisis right now, and who's benefiting and who's suffering from our ongoing policies related to that. You know, I used to tell my students when I was young and naive that American drug policy was evidence resistant, but now I feel very comfortable, and I have your book to thank for it. I'm just saying it's just flat out evidence denying. You know, the federal government maintains that all the drugs that it effectively criminalizes by putting in Schedule I, heroin, cannabis, peyote, LSD, they have no medicinal use and they're highly susceptible to abuse or addiction. But many of those drugs, and Dr. Carl Hart, you talk about this all the time, and I love it, are routinely used medicinally in other countries. And exactly 0 of them were criminalized for the majority of this country's history, which people don't really understand. So my question for you to help the audience that struggles with this is, how in the world did we come up with a way to characterize drugs, you're a scientist, as either good and legal or bad and illegal? That seems entirely divorced from the science. Like, what the heck's going on here, Dr. Hart?
Yes. So if we think about when we first started to regulate these drugs, so like people oftentimes think about the war on drugs as being a recent phenomenon with Richard Nixon in 1971. That misses the point. The first federal drug laws were passed in 1914, and they were passed in order to restrict the use of opioids and cocaine. Originally, the law was seeking to restrict the use of opioids because of our hatred of Chinese Americans who had brought with them the habit of smoking opium when they were brought over to help with the railroads and a number of other projects in the country. And then our racism towards that group of people vilified the activity of smoking opium. And then so local governments and the federal government tried to regulate the opioids, opium in particular. And San Francisco became, I believe, the first local government to regulate opium in 1875. But 1909, the federal government tried to regulate opium in order to show the Chinese government that they were in solidarity with them, because the Chinese government was not happy with the opioids because they were forced to buy and take the opioids from the British in this sort of the opium wars. And then so the US government, in its efforts to show that it wasn't racist, although it was, they said to the Chinese that they would push an international treaty on opioids, starting in our country, passing this sort of federal law that would regulate opioids. And in 1909, Congress rejected this because it was silly to have a federal law regulating drugs when it was inconsistent with the national sort of promise, life, liberty, and the pursuit of happiness, as long as you don't bother anyone else. So Congress rejected that. Then you fast forward a few years to 1914. By this time, the senators and the congressmen had got smart. They had added cocaine to this sort of legislation, and they frightened the population by saying that Black men, particularly when they used cocaine, they became dangerous, murderous. They became unaffected by 32 caliber bullets, forcing Southern police forces to shift to a larger weapon. All of this sort of hysteria, hyperbole, these exaggerations were believed, and they contributed to the first laws passed restricting opioids and cocaine. Those were the first laws. And then in 1919, we passed alcohol prohibition, in large part because of our hatred of the Germans. Remember, World War I was happening at this time, and we had German Americans who were in the alcohol industry. And so that helped to pass alcohol prohibition. But by 1932, 33, we overturned prohibition with the promise that the taxes from alcohol would be sufficient such that we would not have an income tax. But the damage had been done. We had learned how to vilify groups with drugs. We knew that it wasn't too cool to say that we don't like certain groups because of their race, but you could easily say that we don't like this activity of cocaine use by this group. Now you vilify the activity associated with the group, and then you don't look as racist. And so each drug law, when we restricted cannabis use in this country in 1937, we attached that activity to Mexican Americans and Black Americans in order to pass those laws. So every drug law at the federal level has been passed in large part because of our hatred or that drug's association with a group that is despised. So drug laws that restrict drugs in this country, are not passed because of some inherent dangers of the drug, but they're passed because of our racism and our classism. And we can trace every drug law back to that sort of that view, that thinking. And so people who think that drugs are restricted because of their inherent pharmacological dangers, that's naive. I try to help people to understand that in the book. For example, heroin is a medication that's used where I'm at now in Switzerland, in the UK, in other countries in Europe. It's a perfectly fine medication used for pain, used for treating opioid dependence as well. In the United States, in the 50s and the 60s, it was argued in the medical literature that heroin should be available as a pain reliever. It's as effective as morphine and might even provide relief that's quicker, but heroin is just made based on modifying the morphine structure. So I try to communicate this in the book so people are not operating under these delusions that have subjugated specific people groups in our country.
Yeah, and when you get in the drug class too, you start really noticing the discrepancy, right? You said the smoked opium gets banned, but at the same time, morphine is available over the counter, widely used by white Americans, in fact, doctors and professionals and Civil War veterans and all this. And we know that story. Well, that drug has never been on Schedule 1, but heroin is. I've heard you do this before, and you were just so good at it that I'm going to take advantage. Can you explain the difference between heroin and morphine? You do a really good job of that. That's the only opiate that's on Schedule 1 in the United States. Dilaudid, you get the fentanyl, oxycodone, hydrocodone, everything else is Schedule 2, 3 or lower, but heroin has been long time banned.
Yeah. So when we have the morphine structure, all we do, the Bayer Aspirin Company, back in 1874, I believe, they just simply attached two acid groups to the morphine compound, and voila, that's heroin. People have said that attaching these two groups to the morphine structure makes it more lipophilic, meaning that it crosses the blood-brain barrier more quickly. But the empirical evidence in humans is limited. In effect, they are the same drug. I mean, when the receptor in the brain is binding the morphine structure, so they are the same drug. And I try to make that clear in the book for people to understand. And that's why heroin is used medically, just like morphine is used medically in our country, just like fentanyl is used medically in our country, and it's been used in our country for since the 1960s. In fact, fentanyl, the population has gotten crazy about fentanyl, but they need to know that fentanyl comes in lollipop formulations. So children who may have cancer or some really severe pain, they are prescribed fentanyl, and fentanyl is a safe medication as long as people understand that they have fentanyl and the dose. It only becomes dangerous when people don't know that they have fentanyl, and small amounts of fentanyl are really potent. That is, just takes a small amount for it to have an effect. And so you don't want to overdo it. And sometimes people think that they have heroin when in fact they have fentanyl. And that's when it becomes dangerous, because if you take the same amount of fentanyl that you typically take of heroin, that may be enough to cause an overdose in some people, particularly people with limited drug use history. And so it's not the drug that's so dangerous, it's the ignorance that's killing people. And one of the things I try to argue in the book is give people solutions how to decrease this ignorance. For example, when people buy drugs on the street illicitly, we can set up these facilities where people can have their substances tested. Just submit small amounts, and then you get a chemical readout of everything that's contained in the substance that you submitted. And if something like fentanyl is in it and you weren't expecting it, you can possibly save a life that way. This is what they do in Spain. They do this in the Netherlands. They do this in Switzerland. They do this in Colombia. They do this in places where they care about their people. This technology is available in the US, but we haven't made it available to the people.
I appreciate you saying that. I did want to get back to the opioid crisis and maybe some parallels with alcohol prohibition, which I know you're an expert on, and the sort of iron law prohibition and fentanyl that you're talking about. I'm a huge fan. I've watched several of your interviews, and I know that folks who take progressive views on safe supply of drugs and are harm reductionists and are looking for safety, and you're out here talking about responsible use, people being safe. You've gotten a ton of pushback, and even more than I may have anticipated, to be fair. And many of these folks, when they're talking to you in the interviews, cannot resist lapsing into these old myths about good and bad drugs. And I hear them saying this to you, and you're trying to explain it. So one of the things I was hoping you could talk to us about today is, there's this, of course, myth right now that like anybody who's taking a prescription opioid is automatically going to get addicted. You've heard this with use disorder related. If you take one hit, I think it is Dr. Carl, right, of the heroin, you're one puff of the crack, you're gone. Can you sort of explain? You do such a good job with this in the book, and it's so straightforward. Can you just break down some of these myths and tell us how it really is?
Yeah, so it's important for people to understand, by definition, drug addiction. So drug addiction is where people have, this is the sort of medical definition, this is where people have disruptions in their psychosocial functioning, where they're not meeting their obligations. That's one component. And then another component is that the person themselves are distressed. So you need both of these components. So people can, for example, not meet their obligations, but not be distressed about it. We can think about now that we're in COVID, this COVID time, people have started to reevaluate the meaning of their life. And so some people have quit those oppressive jobs and they're not distressed about it. And so if people are, for example, using a drug and not distressed about not meeting those obligations, that's not drug addiction. They are making these choices. They understand what they're doing. The distress component is necessary. That's drug addiction. So when we think about the medical definition of drug addiction, the vast majority of people who use any drug do not meet criteria for these things. So when we think about something like cannabis, maybe less than 10% of people will become addicted. Something like cocaine, maybe 15%, alcohol, about 15% as well. Something like heroin, maybe a quarter to a third will become addicted. But when we think about opioid prescription medications, very few people who are taking these medications for pain, chronic pain, become addicted. Less than 0.8% in many cases. And then you may have, say, 5% on the extreme large end, but that's an aberration even. The vast majority of people who are prescribed opioids for pain never will meet criteria for addiction. In fact, their lives are improved because they are allowed to live their life in a way that is devoid of pain. Pain is an awful sort of experience. If anybody have been in pain for any period of time, we all know that. And we have these medications that work, but we're not prescribing them because of the hysteria around the opioid crisis. Now, it's important for us when we think about the opioid crisis to understand what people mean when they say opioid crisis. They like to conflate these things. They talk about overdose, they talk about addiction. So when we're talking about addiction rates are not out of control. I mean, as I pointed out just previously, most people who use any of these substances never will become addicted, and then even fewer who are prescribed these things. So it's not an addiction crisis, but one of the things that the media and people who talk about this like to conflate is the overdoses with addiction. They conflate these things. So it's important for people to stop them and say, please tell me precisely what you mean when you say opioid crisis. And if they say, okay, overdoses, well, let's look at overdoses. I talked about overdoses. Now, people say opioid overdoses are responsible for 100,000 deaths in this country. That's just simply not true. I mean, when we get these large numbers like 90,000, 100,000, that is anybody who died with a drug in their system. That could be a prescription medication like something that your doctor prescribed for depression, antidepressant, that could be over-the-counter medications in some cases, but those are not all opioids. When we think about how many people die with an opioid in their system in the United States, the most recent numbers is about 50,000. If we say 50,000 Americans die with an opioid in their system. The vast majority of those people had multiple drugs in their system when they died. And then, so the next question you ask is, well, did you all measure the levels of these drugs in the people's system? Then, so you can maybe get an idea, an estimation of which drug caused the overdose, if there was an overdose. That's rarely done. In fact, some jurisdictions don't test for all drugs, and they don't, or some don't do testing for drugs. And so, or if they do testing, the testings aren't consistent. And so that's why it's important for people to really go deep into the numbers to try and figure out, what are you talking about? A large percentage of these people also may have had a drug like fentanyl in their system at the time of their death, not knowing that they had fentanyl, thinking that they had another opioid like heroin, which is less potent than the fentanyl. And so again, if the fentanyl was a reason for the overdose, this was an accidental overdose that could have been prevented if we had drug checking services. And then also people combine opioids with other sedatives in some cases, not realizing that that can increase respiratory depression and increase the likelihood of someone maybe overdosing. So you want to make sure people understand these sort of things. And then the role of Tylenol is almost never considered. Tylenol is the number, Tylenol, of course, has acetaminophen. That's the number one reason for liver toxicity in the world. And so people sometimes die as a result of this. And many of our formulations in the United States, pain formulations like Percocet, Vicodin, those drugs contain a small amount of opioid, about 5 milligrams of oxycodone, for example, and 325 milligrams of acetaminophen. You only need to take 10 to 20 of those pills on consecutive days in order to shut down your liver from the acetaminophen or the Tylenol. So the problem becomes the Tylenol, not the opioid, but the media. People focus on the opioids because right now, they are the sexy things to focus on. But if you focus on that, you don't really care about the American public. You are virtue signaling, pretending that you care about the American public. And so this is what I tried to do in the book, to help people to break down, to understand what the real concerns are and what are the hysteria and the nonsense that are causing distraction and not allowing us to focus on the real problems that people may actually face.
Yes, I really appreciate that. I think there are a ton of myths around all of these things. You know, I can't resist asking you about this, but one of my favorite parts of your book was when you talk about meeting Tom the lumberjack from Idaho. I just had no idea that backstory. I mean, that if you guys don't buy this book for any other reason, and you should buy it for a million reasons, you've got to read this chapter. And it's about the guy who wrote, I guess, The Godfather Part 3, but ultimately New Jack City. Dr. Hart, would you at all be willing to, engage with me here and sort of tell that story? I think it teaches the reader a lot of things about what you're talking about.
Yeah, so this is back in 2015. I was here in Geneva, actually, and I got an email from this guy, Tom Wright. Tom Wright, my grandmother, my maternal grandmother's last name is Wright. And so I got an email from this guy, Tom Wright, and he basically said, yo, why you dissing my movie? Because I had said something about New Jack City, how that was not reality, that was just some fiction, bad fiction that people promote and say that's how it was in the hood with crack. And that's just bullshit. That's just a lie. And so I was saying that on some show, and then Tom wrote me an email saying, yo, I'm the writer of New Jack City. and why you dissing my movie, just kind of joking. And then we made a plan to meet when I came back into New York. When I got back in New York, we set up a time to meet. Tom would meet me in front of Columbia, the Columbia gates at 1:15. And so, it's New Jack City. And I saw New Jack City. New Jack City was the New Jack era. People like Teddy Riley, all of those cats who dressed like New Jacks. And so I'm looking for Tom at the gate because we were going to meet at the gate. So I'm looking for a brother who, looked kind of hip. And I walked past this cat who kind of says hello, not knowing that it's Tom because he has on this like lumberjack shirt, this white guy who's like a 6'2" or so, big white guy looking like a lumberjack. And that's Tom, the cat who wrote New Jack City. And then Tom told me that originally this movie was Godfather 3. The studios rejected it in part because it really became like a tribute to Nicky Barnes, I believe, the guy from Harlem who was the drug dealer in the 70s, the brother. And the studio couldn't have a Godfather 3 or Godfather movie be about this brother. It's an Italian white film. And so they allowed Tom to shop his movie to other studios. Quincy Jones, I believe, over at Paramount scooped it up. And the rest is history. They brought in another brother to help to massage the story. And they hyped it up, and that's how we got New Jack City. New Jack City, the primary writer is this white cat from Idaho, and people act like, oh, that's from the hood, that's hood stuff. No, it doesn't work like that. And so this is, I try and help people to understand, like, this is how you all get hoodwinked. And then we start creating these stories and start believing this nonsense. And acting as if this is something to be proud of. Mind you, Tom is mad cool. I dig Tom. He's a really cool cat. He's done a lot of other stuff. And I consider Tom a friend.
Yeah, I found that to be quite the eye-opening story, given how culturally important that movie ended up being, and that was just fascinating to me. I have an audience question I'm gonna ask you, and then I'll go back to my questions. You guys jump in here if you want to. So the first question, you won't be surprised. We've already alluded to this. It says, I've not read your book and would appreciate learning more about your main point. Are you suggesting all drugs should be legal? Do you have concern about the use of substances and negative impacts on lives? What are your suggestions for managing drug use that does not become addiction?
Yeah, thanks for that question. My point is really clear. One of the things, like as you pointed out, Jennifer, the subtitle of the book is "Chasing Liberty in the Land of Fear." So I refer the questioner to the Declaration of Independence, for example. It's a short document, and it lays out the sort of promise of the nation, the original promise. And it says that we have 3 birthrights: life, liberty, and the pursuit of happiness. That is, you can live your life like you see fit, so long as you don't disrupt other people from doing the same. You don't impact or infringe upon their rights. And then in the next sentence, it says that government should be created to secure and protect these rights and disband it when it doesn't do that sort of thing. And so my belief is that, these substances, the substances that people seek, cocaine, heroin, MDMA, cannabis, these things should be available for adults, and we can talk about unit dose, how much is actually in it, routes of administration that could be, that these things would be sold under. We know a lot about pharmacology to enhance the safety of these things. States are moving this way with cannabis. Increasing numbers of states are legalizing cannabis. Oregon, decriminalize all drugs, make sure that people don't go to jail for using these things. But I'm arguing for legal regulation so we can have quality control. That is, between 1920 and 1933, tens of thousands of Americans were maimed or killed because of tainted alcohol. when we legally regulated the alcohol market in 1934, so once we overturned prohibition, those deaths went away. The maiming went away because we had quality control. And I'm arguing that we should do the same sort of thing with opioids and other drugs, so we can take out these contaminants that are in these substances. And the contaminants are what's really causing the problems. And we can also begin to have honest education about these things, and helping people to understand what routes of administrations are the safer routes of administration, which conditions, the doses that are more likely to increase the positive effects and decrease the negative effects. By the way, we give these drugs in our laboratories at Columbia. I built a career on this sort of thing. We give thousands of doses to research participants every year. And we have created this database that's there for the public in order to help people to understand the conditions under which negative effects are most likely, under which positive effects are most likely. So yeah, I'm arguing for legal regulation for adult use. And please understand that addiction has almost nothing to do with the drugs themselves. Addiction has everything to do with the psychosocial conditions under which the drugs are taken, under which people are experiencing. So that is people who are experiencing, for example, high rates of unemployment, who are marginalized. They are far more susceptible to being addicted to people who are not. So those are the kind of things that we need to attend to in our society if we care about drug addiction. Our focus on drugs allows us not to focus on the person's problem, on the people's individual conditions. Politicians want us to focus on the drugs. Law enforcement wants us to focus on the drugs because they all look like heroes, but that's not solving people's problems.
Yeah, I often bring up, maybe you'll appreciate this, that the term drinking yourself blind does not come from actual like alcohol misuse disorder. It actually comes from the fact that the government poisoned the alcohol supply. It wasn't a safe supply. And so people would literally go blind. And as Dr. Hart pointed out to you, tens of thousands of people succumbed to a poisonous supply of alcohol during alcohol prohibition. And we saw that precipitously decline once there was to his point, safe supply. Okay, here comes the questions now. So the next one is, what's the most, I have a related question to this. This is great. What's the most unexpected thing you've learned on this journey while you wrote the book and since its release? And my follow-up to that is just, what's been the reception to you sort of quotes unquotes coming out of the closet and writing this, very courageously writing this book?
Yeah, I guess one of the most unexpected things about this particular book and this journey has been the attack by the left. When I say the left, I mean really the kind of liberals who are white moderates, as King called them in the Birmingham letter. Largely white male writers who like their psychedelics. And they don't want to get out of the closet because the activity that they're doing, people are going to jail for. And then people want to say that they are allies when in fact they are betraying the people who are catching hell. They're not allies. And so I've been attacked by those writers. In fact, one person from the New Yorker, writer, I believe his last name is Wallace. This clown argued that staying in the closet is the responsible thing to do in order to like hide and conceal his own drug use. I mean, he didn't say that he used drugs, but it was so transparent. That was the most cowardly sort of thing that I have observed on this journey. But there are a number of sort of cowardly acts like this by those type of writers. My encouraging them to get out of the closet in order to stand up in the face of unjust laws, just like people like King and those people stood up and were willing to be arrested for unjust laws. these drug laws that restrict people's desire or right to use are inconsistent with the founding principles of the country. And nobody is saying anything about that. And not only that, they're causing more harm, more destruction. They are allowing people to be incarcerated, their lives to be destroyed, and people are fine with that. And I can't be a party to it. And so that's been the biggest sort of surprise, the cowardliness of those in the media and the attacks of people on the left. Now, when you look at High Price, the book before, I was their darling because they could use my story to fit their own sort of way of thinking. And so that's been the biggest sort of surprise, the biggest disappointment. But I think that many people, when they read the book, they see through that cowardness and that betrayal. And so people can't consider themselves allies when they're not standing up on behalf of people who are suffering.
Yeah, I have to tell you, I mean, you're not going to be surprised to hear me say this, but I have been shocked at the moralizing and some of the commentary that really you've gotten. I've heard people say things to you, but like, that's not a plant when they're talking about opium or products, opiates, and you turn right around and correct that, or the addiction rates. I mean, they will always even subtly justify the drugs that, again, they've put into the good category, right, for themselves. And those that they haven't. You often, as a follow-up, talk about why it's harder to hoodwink or fool the folks when it comes to cannabis now. And I was going to ask you to maybe share that and motivate us on how we may make some progress going forward based on that lesson.
Yeah, with cannabis, it's more difficult to gaslight people because more than half of Americans have smoked cannabis. So you can't do what they did in the 1930s. Harry Anslinger, the first sort of chief of the Bureau of Narcotics, he had these advertisements and blasting the media sort of with these inaccurate portrayals of marijuana users, saying that, somebody smoked marijuana today, tomorrow they're going to be doing heroin and murdering their parents. And he was believed with this sort of thing. You can't say that today and be believed, because so many people have tried cannabis and know that just simply isn't true. But you can say that kind of thing for heroin. You can say that kind of thing for methamphetamine and be believed. This is one of the reasons that I came out of the closet, having tried all of these drugs, because I wanted to say to the public, we give these drugs to people in a lab. And so we observe this. I mean, your tax dollars pay for researchers at places like Columbia to give these drugs to research participants. And so, but I wanted to put myself on the line and say, okay, someone as productive as I am, multiple books, hundreds of scientific articles, lectures all around the world, meet all of my obligation, kids are doing well, all these sort of things. Now, now I use these drugs, now what do you say? And remarkably, which this has been a surprise to me, people have said things like, oh, you're in denial, you're an addict. It's like, what the fuck? That's the most bizarre thing. It's like, well, if I'm an addict, then you want your kids to be an addict, because then those people will have fought in the military. They will have published all of these papers. They will have done all of these things to serve their community. All of that is disregarded, and people just focus on the fact that I said that I've used the drug, and that's been remarkable. And the idiots who say these things to me have nowhere near the accomplishments that I have in life, and that's the thing that just blows my mind. That blows my mind.
Yeah, it's rough. I would give you a break from that for a minute and move on to a very interesting question. One of our audience members wrote in and said, do you think the disease model of addiction creates a sense of learned helplessness? I've been in behavioral health for 3 years, and I'm tired of telling patients that their brain is, quotes unquote, defective.
Yeah, thank you for that question. I wish the reader should check out chapter 4 in the book. I really take my time to help people to understand how this brain disease model is actually promulgating and promoting social injustices. Because what it in effect is doing, well, let me give you an example. We said that methamphetamine caused this neurotoxicity. This is what we told people. Methamphetamine is my main area of study. And back in 2012, I published a critical review of the brain imaging literature on methamphetamine to see what was actually going on with methamphetamine users' brain. What I concluded was that the brains of methamphetamine users were similar to those of people who didn't use the drug, and you couldn't discern their brain imaging photos from anybody else's. And then when you looked at their cognitive performance, they performed within the normal range. But the story was that methamphetamine caused all this damage. President Duterte over in the Philippines got wind of this message and went after methamphetamine users and people who sold methamphetamine. Duterte says that methamphetamine shrinks the brains of people who use that drug. After about a year of use, these people are no more are unable to be cured, or they are irretrievable. So therefore, we can kill them. Duterte's war on drugs has killed thousands of people, in part operating under this misguided notion that these folks are brain damaged. The science does not support this, but that's an extreme example of what happens when we promulgate this misinformation about drug addiction, drugs causing brain damage or brain disease. By chapter 4, I go through the evidence to help people to understand how they are being misled, and help them understand that the data does not fit that story.
Thank you for that. The next question is right back to opioids. And the question is really, it's involved. It's sort of asking if you've reached out to a bunch of different famous people like Rashida Jones, Rachel Matthew, Lawrence O'Donnell, in order to correct the narrative. And I'm going to frame this question a little bit beyond that and just ask you what you would ask us or advise us to do. We have a complex problem here. You've already well described this. It's based on a lot of factors and very individual factors, and it isn't about a particular drug, right? But this drug has been villainized in such that more and more people are dying every year of polypharmacy deaths and complicated involved deaths, as you described, and pain patients are suffering who had improved lives and were able to actually, be with their families and go to work, are now debilitated because they've been, rapid tapered or abandoned by medical providers. Is there anything we can do at this juncture? Things just keep getting worse that could turn this around, or is there any way to work this narrative in a way that people can have more compassion or more understanding?
Yeah, it's important for all of us to reject these films that come out about the opioid crisis, that have these simple narratives that vilify the pharmaceutical company. And by the way, I'm no friend of the pharmaceutical companies. But when we go and we vilify these companies, what we're doing is saying that these drugs can't be used. And that's just simply not true. There are people who are benefiting from the use of these drugs. And so our narratives have to be a lot more nuanced, and we have to be aware that there are people who are suffering, particularly when we go after a substance. It's never about the substance. And when we also think about the experts that people bring on to talk about drugs, the question you want to ask is, have those people ever published anything in the scientific literature on drugs? Oftentimes, no. They're just personalities, and they're and they know nothing. You have the Dr. Drews of the world, these people who know nothing about drug addiction, never published in the scientific literature, but they are held up as experts. And so when you start to see these kind of things, you need to speak out. You need to write your papers, the newspapers, and you need to say something to those organizations that are promoting this sort of thing. When you read in the newspaper about the opioid crisis, make sure you understand what the reader is writing. What are they calling the crises? Addiction rates, overdoses, what are they calling the crises? And make sure that they separate these things, and then make sure that you understand that they understand that they actually have evidence that the drug caused the overdose before they say this sort of thing. I hope that this helps, that ask the right questions. In the book, I explain how we count drug overdose deaths in this country. It leaves a lot to be desired. Most of the death investigations are being done by coroners and not medical examiners. Medical examiners have a medical degree, at least some training, even though they have a lot to be desired. But coroners, the only thing that many of these folks have are high school diplomas. And these are the folks who are determining how people died. And that's a problem. In the book, I lay this out and I show how this has artificially inflated these numbers that we're calling opioid overdose deaths. And so it's important for people to ask the right questions. What were the levels? What were the drug levels in the person's system? How did you determine that this drug caused this death? Oftentimes that information is almost never presented, but yet we call it a drug overdose. And so what that does is that it gives justification for people to say, we're going to ban this drug. And when we start to go ban drugs, that means that we're not looking at the real problems that people face.
Yeah, I get demoralized sometimes. And you told this wonderful story about Tony Soprano, and I'm going to just tell the audience really quick. You've got to listen to his interviews, and it just really brings it home. Where Tony's just murdered someone. Everyone knows his show. He's a murderer. That's what he does for his job. And he comes and picks on his nephew Christopher, who's doing drugs, and he's just murdered someone. And it's a moment where the audience is meant to feel, and does feel, compassion for Tony Soprano, who has just killed another human being. So I sometimes worry about these movies and media depictions. It would be really boring if you and I, sir, were in pain and we took a drug and we just got up and did our job and felt a lot better and were cheerful. That film may not sell. I'm going to ask you, I know we're getting towards the end of the time. I have one more question. And this question is about, it says, you talk about the stress of the drug user being key to addiction. Can you discuss if and or how the user would be affected differently with or without the distress and the drug use? I think just wanting a little more information about how you sort of distinguish those things.
I'm sorry, can you say that again? The distress, how do we separate the distress?
How would what would be the difference between someone who used a particular substance at a particular time and then was in distress and wasn't? Is one automatically going to potentially lead to addiction or not? We're sort of just saying they'd like to get more information about how much impact distress has on someone when they're actively engaged in drug use.
Yeah, let's just think about alcohol use. You could think about anybody's using alcohol at a bar with friends, hanging out. Do they feel distressed? They're watching, they spend, for example, their entire Sunday watching the National Football League, and they didn't do anything besides watch the game. They didn't accomplish anything. Do they feel distress? Like sometimes when I don't accomplish anything, I can't watch an entire football game because I don't want to waste my time like that. But other people don't. They're perfectly fine with that. There's no distress, and then that means that those people they're good. The same is true when people are using something like cocaine or MDMA or heroin. The same is true. So we don't need to create any new sort of ways of looking at this. We already have psychoactive substances that people use. We just need to look at those substances in a similar sort of rational way that we look at alcohol use. Our sort of thinking about cocaine versus alcohol or heroin versus alcohol is so skewed that we tend to think of drugs like cocaine and heroin as having magical properties. They don't. They are just inert chemicals waiting for a biological system to interact. So it really has to do with the person, the person's personal situation, the environment. All of these things are far more important in terms of how a drug will affect the person.
Thank you so much. I do see we're at time, so I didn't know if the host was going to let me crowbar in another question, but if not, I just want to say this has been an absolute pleasure. Thank you so much for all the work that you've done. I highly recommend the book to everyone. There's wonderful stories, wonderful narratives. I guess I will ask you, they just told me I could ask you one more question. I was wondering if you just take a closing moment to explain to folks that how much you have evolved on this issue yourself throughout your career. I always find that fascinating to listen to as well.
Yeah, thank you for asking that question, because in the book, I describe how I was a drug warrior myself. You know, I thought that people should go to jail for using drugs. I thought that drugs were destroying the community from which I came. And so I believed all of these sort of things that many people believe. But then after 30 years of studying drugs, it's been more than 30 years now, I've been studying drugs and giving drugs to people in the lab. I was forced to reevaluate my view on this. It's like I give a drug like cocaine or methamphetamine to people in the lab. They show up, they're responsible, some of the most responsible people I've met, and they're happy, and they are chilling. And it's like, wait, we said that this drug was evil. We said all of these things, but I'm giving these drugs to people in the lab. That caused me cognitive dissonance. It caused me to evaluate the real numbers of people who become addicted and to look deeper at what's really going on. In fact, my giving drugs to people in the lab actually contribute to me trying drugs and seeing how these things could be beneficial. So this is what you want in your scientists, to follow the data and follow the evidence. So that's who I am. I try and be a true scientist. I changed my views based on where the evidence dictates. And this is part of my evolution. And I hope, it's important too. One of the things I try to communicate in the book is that the goal is to make sure that people are happy and people are enjoying their lives. Because if they are happy and enjoying their lives, they're more likely to treat others well. That's one of the major themes of the book. But I have been forced to be defensive about this sort of thing that people are doing. And when in fact, the book is really about love and allowing people the space to enjoy their life responsibly, of course. It's been remarkable seeing how many Americans want to tell other people how they should live their life, especially when those people are not disturbing other people. That's wrong. That's un-American. As long as those people are not disturbing other folks, we have no right to tell them how to live their life. Now, I have to say this too. We're in COVID, and that does not mean that you don't have to wear a mask in public. I have to wear a mask in public because if I don't, I might disrupt somebody else's ability to enjoy their life. So that's not this superficial mask sort of thing. That's not what I'm talking about. I'm talking about like real liberty, not this superficial political thing that people have created.
Well, thank you so much for that. I just want to say to everyone one more time, I have it sitting right here as I always do. The book is terrific. I also want to mention, if you're someone who likes to listen to books while you walk or exercise like me, Dr. Hart narrates the book himself, and you can really powerfully feel those stories because he's retelling you people that he's interacted with. And I also highly recommend that for folks who want to listen to the book and you can hear him tell the tale himself. So thank you so much, sir, for your time. It's been an absolute privilege to be with you tonight.
Jen, thank you so much for doing this. Mad love that. I can't wait to see you in New York.
See you in New York. Travel home safe.
Thank you so much for leading this conversation. I'm so glad you two got to meet and you got to talk about this. And Dr. Carl Hart, I couldn't thank you enough for being here, for sharing yourself, being vulnerable, and educating people on this narrative that desperately needs to be backed up with truth and justification. And you are the person to do that. So thank you so much. And everyone at home, please, yes, of course, please purchase your copy from our partner bookseller, Third Place Books, and that link can be found in the chat. Thank you both so much, and to our audience, have a great night. Thank you.